Good evening, one and all. On behalf of Hetero Healthcare, I welcome our faculty and all attendees for joining us today for this academic treat. As an organization, Hetero Healthcare has been consistently conducting educational initiatives through physical CMEs and conferences and now on digital platform during this COVID pandemic this year. When we mention COVID-19, it's important to mention the tremendous efforts put in by Hetero Healthcare to bring in the India's first remdesivir brand Covifor, which has been serving over 1.5 million patients till now. We also made available favipiravir and hydroxychloroquine immediately after that. Our efforts didn't stop here. We have recently launched methylprednisolone, which is the brand Prednivik, and baricitinib for COVID management. Our brand approval for Tosera, that is tocilizumab, has been already announced, and the clinical trial on an oral antiviral, that is molnupiravir, is ongoing, and we are expecting approval soon, though we hope that we do not need it henceforth. Apart from the COVID-19 pandemic, Hetero has been instrumental in bringing in molecules for management of HIV, HBV, HCV, and even H1N1. The Indian pharma industry has witnessed tremendous success in biosimilars, in managing various autoimmune diseases and improving patients' quality of life. Hetero has also developed and strengthened its biosimilar manufacturing unit by successfully introducing molecules like rituximab, adalimumab, bevacizumab, and the recent one was tocilizumab. The ever-evolving medical science has always motivated researchers to analyze and introduce new class of drug and molecules. One such new class of drug is JAK inhibitors, and it has been successfully used for various autoimmune diseases management. The international approvals for tocilizumab is for RA, rheumatoid arthritis, ulcerative colitis, psoriatic arthritis, and juvenile idiopathic arthritis. In India, it has been approved for rheumatoid arthritis and is also being explored in various dermatological conditions. So thus, this webinar has been crafted with an expert panel on board to address JAK inhibitors use in dermatology. To navigate us through this for the couple of next hours, we have our moderator, who is one of the most experienced clinician in dermatology, Dr. DG Saple sir. I'll introduce him today for this program. So DG Saple sir, frankly, doesn't need an introduction. He is a well-known dermatologist throughout India. He is an honorary professor and head of dermatology, venereology, and leprology in Grand Central Medical College and Sir JAKi Group of Hospitals, Mumbai. He's been involved in clinical management, research, and training program of HIV and AIDS for the past 30 years. But he has published many international papers and delivered more than 1,000 lectures in India and abroad, and the number is still counting. He is the ex-president of IIDVL Maharashtra branch. He was awarded with a Lifetime Achievement by IMA Mumbai in 2017, Lifetime Achievement IIDVL Maharashtra in 2018. He was awarded the Best Practitioner by National and International Conference of Dermatologists in 2019. And he was felicitated by IIDVL Fellowship Program Dermacon Pune in 2020. He is the first dermatologist to start fluconazole daily therapy in dermatophytosis. We welcome you, sir, and over to you. He's always been our mentor and guide. Over to you, sir.
Thank you, Shweta, and thank you, Hetero Healthcare speakers, panelists, and the audience for giving me this opportunity about this program, that is use of JAK inhibitors in dermatology. Today, there is slight change in the program. Dr. Yogesh Preet Singh is not able to join, and Dr. Jindal is not going to join. So we'll have one talk from Dr. Tarun Mittal, then followed by Dr. Rakesh Bharti, who is going to present his cases. After that, we'll open for the panel discussion. And after panel discussion, we'll take questions from the audience. So in this program, our first speaker is Dr. Tarun Mittal, who is a consultant dermatologist and aesthetic medicines with the practice of for last 22 years and a senior consultant at Synergy Institute of Medical Sciences. He has been confirmed with Uttarakhand Ratna Award. He has got a best skin care center and the laser clinic in Uttarakhand, and he has held various positions in IIDVL. He is a part of the organizing of many conferences, and Dr. Tarun Mittal is very active in IIDVL at the national level. I know it. So we'll request Dr. Tarun Mittal after I introduce panelists. Of course, our next speaker was Dr. Yogesh Singh, but because of some problem, he is not able to join us. So we'll start with the panelists. Our first panelist is Dr. Rakesh Bharti. Dr. Rakesh Bharti is well known, as per I know, in a management of HIV/AIDS, Rakesh Bharti and Saini. These are the two people I know from Amritsar. They are very well known for managing HIV. He is a consultant, of course, dermatology and mainly the sexologist from Amritsar. He was office bearer for IIDVL. He has designated HIV specialist by American Academy of HIV Medicine, and he has also delivered and chaired many lectures at national and international level. Our next panelist was Rohit Kumar Jindal. Unfortunately, he is also not able to join, but we have very well known, very academician, Dr. Davindra Prasad, which is very well known on pigmentary disorders. He is a professor of PGIMR Chandigarh, honorary professor of dermatology, University of Rome, Italy. His area of research is vitiligo, no need to mention, but he has done a lot of work in vitiligo, probably one of the pioneers in vitiligo, about the pathogenesis, treatment of innovative surgical method. Total 325 publications, about 180 publications only on the vitiligo. He was a past president of Asian Society of Pigment Cell Research, that is 2011 and 2014. Coordinator of Asian region for World Vitiligo. So you mention anything of vitiligo, Dr. Davinder is there. Of course, he is editor for Biomedical Research International Associate Editor and Archive of Dermatology, Research Dermatology Therapy, and member of editorial board of International. So Dr. Davinder, welcome, and we'll go for our next panelist. Dr. Dimple Chopra, she is from Patiala. When you talk about Patiala, everybody remembers the Patiala pig. But of course, Dr. Chopra is very well known. She is the head of the department, skin department at Patiala, and has more than 35 publications. And she is more interested in acne, psoriasis, urticaria, and the research. So we have a good group of the panelists, very good. Dr. Mittal as one of the experienced speakers. So I'll request Dr. Mittal to go ahead with his talk.
Thank you, sir. Just hold it, sir. I'll restart it. Can everybody see this? It is fine? It is there? Everybody can see this?
Yeah, it's perfect.
It's perfect. Okay. So at the outset, again, I would like to thank hetero people for organizing this meet, and the person who was instrumental in this the total program. The brainchild was none other than Dr. D.G. Saple sir, and we started off with this talk on tofacitinib, and I am highly thankful to him. I am thankful to the panelists, Dr. Rakesh Bharti sir, Dr. Dimple, and Dr. Devendra Prasad, who took off their time. And again, I would like to thank all those people who would be joining this talk, and I hope they will be benefited. Another thing, what I would like to add here is I have a very bad throat, so you will all have to bear with me. So, friends, the topic for today would be these JAK inhibitors. And I think what I feel is JAK inhibitors has been a new game changer in dermatology. This is what I could foresee. Just 20 years back, I remember Dr. Devendra Prasad was here with us at Dehradun only when I started my practice. He was at Jolly Grant, and we dermatologists was considered just of the value of writing a topical and an oral corticosteroids. So the things changed with the advent of retinoids, then with the advent of calcineurin inhibitors, then biologics. And here I say these JAK inhibitors can be again a change in the twist in dermatology. This is what I could foresee. So there are fewer diseases on which, although it is a very good anti-inflammatory drug, and it has been used internationally on psoriatic arthritis and ulcerative colitis, but as such, what we are pursuing are the off-label indications on which it has been tried a lot in dermatology, and basically it has been tried in vitiligo, in alopecia areata, in psoriasis, in psoriatic arthritis, and atopic dermatitis, to name a few. Apart from these, there are other certain conditions where also it has been tried. But today we'll be focusing on these four main diseases on which we intend to work in near future with this JAK inhibitors. Now there are various JAK inhibitors. So these first generation JAK inhibitors, this tofacitinib is available in our country. So we will be talking mainly about tofacitinib. So now our talk comprises of what is the JAK pathway, what is the pathogenesis of this JAK pathway in these diseases, which we are going to talk: psoriasis, alopecia areata, vitiligo, and psoriasis and atopic dermatitis. What is the need of JAK inhibitors? Do we require another drug in these diseases? Tofacitinib has helped as a JAK inhibitor, how it is working. Then what are the clinical evidences which are there as of now with us in these diseases? So to start with, these JAK-STAT signaling pathway is involved in many inflammatory diseases, but mainly in those which are working with type 1-2 cytokine. So what we find is the major cutaneous diseases, as we have already talked about, is the psoriatic arthritis, the psoriasis, the alopecia areata, the atopic dermatitis, and vitiligo. This is a very good chart, and this shows how these STAT and JAK inhibitors, JAK is Janus kinase and STAT is a part of it as signal transducer and activator of transcription. What this JAK1 and 3 and JAK3, STAT3 and 5 are involved in alopecia areata. With psoriasis, JAK2, DYK2, STAT4 and 3, they are involved, and they directly modulate the IL-12 and IL-13. In atopic dermatitis, we have again JAK1 and 3, STAT3, 4, 5, 6 are involved. Similarly, in vitiligo, we have more involvement of interferon gamma with STAT1 and JAK1 and TYK2. So coming on to these individually, how these JAK inhibitors are involved in psoriasis. We all know about IL-12 and IL-23, which are the markers of inflammation in psoriasis, and we target them here. So these IL-23 are JAK-dependent cytokines. Now this IL-23 is responsible for in the pathogenesis of IL-17. We are well aware that when we talk about biologics, we are targeting the TNF alpha inhibitors and IL-17. With IL-12, we are targeting the TNF alpha and the interferon gamma. So by targeting IL-12 and IL-23, we subsequently target the T helper cells in the TN alpha inhibitors, TNF alpha inhibitors. Now, when we talk about this alopecia areata, here what we see, there's CD8 cells. These are present as the cytotoxic T cells. They start generating this interferon gamma, and again this generates interleukin 15. And there is an interplay of interferon gamma and interleukin 15, which activates the CD8 cells in the follicular, and these are autoreactive T cells, and they are responsible for the destruction of the molecule. So as soon as you stop these JAK inhibitors, they work on interferon gamma and IL-15s, you stop this destruction of the follicle. So CD8 T cells infiltrate into hair follicle. As I told you, they work on the interferon gamma, again into interferon 15, and these T cells proliferate and destroy the follicular epithelium. So if we prevent this function, we are able to prevent this pathogenic process. When we talk about vitiligo, here it is the chemokine 9 and 6. So what happens? These chemokine 9 and 10, they recruit CD8 cells again, and this JAK signaling is activated in CD8 cells, which increases this interferon gamma release. Now this interferon gamma release again leads to increase in these CD8 cells, and these CD8 cells are responsible for the destruction of melanocytes. Although that is very brief, very basic, I don't want to go into details. Dr. Devendra Prasad is there. He is a hero of vitiligo. He knows vitiligo in more than any one of us. So then these CD8 cells target melanocytes, leading to depigmentation. As soon as we use these JAK inhibitors, they start decrease the signalings of interferon gamma, then CXL10 expression, leading to return in pigmentation. Now in atopic dermatitis, we have various molecules, interleukins, IL-4, IL-5, IL-31, IL-13, and IL-17, which play a part. These JAK inhibitors, they are going to inhibit these interleukins, and as such, they help in atopic dermatitis. One very important feature here in atopic dermatitis is the response in the skin pruritus, which is very advantageous because people with skin pruritus do benefit a lot with JAK inhibitors because of these IL-31 inhibitions. So with this, we already talked about the rationale, how we can use in alopecia areata. We already discussed this. Coming up to tofacitinib, now how does it act? So as I talked to you, type 1 and 2 cytokines, they type, am I audible? Am I audible, sir?
Yes, sir.
Perfect.
Okay. So these type 1 and type 2 cytokines, these JAK are associated with this. Now this tofacitinib or JAK inhibitor, here it comes and inhibits. So what is the routine processes? These JAK inhibitors, they go and phosphorylate stats. These stats go and transcript to the gene. They are messengers to the nucleus. Now with the presence of these JAK inhibitors, they stop the phosphorylation of the STAT inhibitors, and as such, it does not lead to the gene transcription. So here it affects the whole change messenger from the cell's membrane to the nucleus is affected. So there are many areas where it works in psoriasis, we've already discussed. Now, when we come to the pharmacokinetics of tofacitinib, I'm sorry, I'm very at bad throat, very difficult. So the absorption is very good, and it has been mentioned by the literature that it is reduced by 32% with a high fat meal. So I think this we should need to understand. And the protein binding is around 40%. The hepatic metabolism is around 70%. With primarily it comes down in unchanged around 30% in the urine. And the half-life of the drug is around 3 hours. So it is very fast to go inside the man. It has a very good, small life is smaller. Half-life is smaller. Now, when we talk about in special populations, pediatric use, here there have been studies where this molecule has been tried in pediatric population. But till now, the data is not so robust. In certain populations, it has been tried in few patients, adolescent population, in alopecia areata, few children, although not much adverse effects were seen. When we talk about the geriatric population, since there is already a higher incidence of infections in the elderly populations, so as of now, I think we should keep tread a cautious path. Again, the same plan for diabetics. Again, a lot of caution has to be there because a lot of infections are already there. Diabetics are more prone to infections, and this drug has been shown to have an increased preponderance of URTI, so that needs to be taken care of. Till now, it has not been approved for pregnancy and lactation. Now, when we talk about the renal impairment, here what we see, when there is a very mild renal impairment, then not much difference of the drug has to be done. Difference in the doses has to be done. In case of there is a moderate renal impairment, then we can reduce the dosage to once a day. Same for a hepatic. In case there is a mild hepatic impairment, then not much need to shift the dose. 5 milligram twice a day can be continued. In case of a bit more of hepatic impairment, then 5 milligram once a day dose can be considered. We need to halve the dosage and still monitor, obviously. Now, various warnings and precautions, what need to be done. So, serious infections are absolute no-no. Any amount of serious infection, if it is there in the body, and we should not start a tofacitinib. GI perforations have been seen to be common, so we need to be take care. Any person with GIT manifestations need to be cautious. Laboratory findings, I'll tell you how to monitor them. Then live vaccines, we should avoid using them. Absolute contraindications, somebody is hypersensitive, pregnancy and lactation, and severe hepatic impairment. You should not use the drug. Now, what is the monitoring? So to start the drug, we should have a routine complete blood count, a creatinine, LFT, a serum CPK levels have been seen to be increased, a fasting lipid panel, serology for viral markers is very important, then screening for a TB, for latent tuberculosis by different investigations is important. At follow-up for 1 month, we can have a CBC, creatinine, LFT, and a lipid profile, which we can go ahead after 3 months. Annual screening of TB has to be there, especially in an environment in India where we are endemic with TB. So drug interactions, although not much, very few, need to adjust the dosage with ketoconazole and fluconazole. With rifampicin, it is not recommended, and with other immunosuppressants such as azathioprine, as such, it is not recommended. Although there are certain reports, there are reports of its use with methotrexate in various conditions. So, adverse drug reactions, although Dr. Yogesh Preet Singh was there, so I will just brief, although much hype has been made for the adverse drug reactions, I tell you, and what it has been seen is most of the drug reactions are there when we are using a 10 milligram BID dose. When we are using a 5 milligram BID dose, then there is a pretty less amount of adverse drug reactions, more of URTI, nasopharyngitis, urticaria, headache has been seen, GI upset has been seen. So these are the few of the adverse effects with a 5 milligram BID dose, which is most common. But you need to have a lookout for the bigger adverse effects, for the grievous adverse effects like non-melanoma skin cancers and other adverse effects have to be there on the back of the mind always. So off-label use, we are talking, it has been recommended for rheumatoid arthritis. It has been sent psoriatic arthritis by US FDA, but this at present it has not been approved for these indications. So we are still in the off-label use. Now, when we talk about psoriasis, there are various studies which we have with us, and this study has been at 16 weeks, and both PGA scaling and PASI score has been done, and we have used 5 milligram BID dose and a 10 milligram BID dose of tofacitinib, and at week 16, around 40% patient had a PGA score of around 40% at week 16 and around 60% a score at with 10 milligram BID dosage. And same for PASI 75, around 40% had a PASI 75 with a 5 milligram and again a 60% at week 16 with a 10 milligram. So definitely 10 milligram scores, but again at the background, the amount of adverse effects it has, so that has also to be kept in mind. Another study again with the same tofacitinib with 960 people it was done, and around about the same results. We have PGA scores with 5 milligram of 46% and 60%, and PASI scores of around 40% to 55%, and 46% to 59% with a 10 milligram BID dosage at week 16. So at 4 weeks. Another important study which I would consider that it was with etanercept. Etanercept has been a benchmark in biologics. It started off, it initially came with us, and what it has been recommended is this 10 milligram BID dose has been considered to be non-inferior to etanercept. So, friends, so we need to consider it as armamentarium along with the biologic with us, because with biologics there are a lot of the costivity is the factor. The oral we can give these tofacitinib orally, so this is an add-on benefit here. Now another study on nails. Nails, as we all know, are difficult to go, and a lot of difficulties there. So this study was conducted, and at 50, NAPSI 50 was at around 32 to 45%, with NAPSI 75 showing around 17 to 28% in 5 milligram and 10 milligram doses subsequently, and 10% to 20% people having even NAPSI 100 scores at week 16. So this is, I think, thing to be thought of. And this another very important factor was this score was maintained till week 52. So even after a year, the patient continued to improve. Another the study was done on an Asian patients. Here, round about the same scores, we were finding around 50 to 75% with the PGA scores, and 55 to 81% the PASI 75 scoring at week 16 with 5 milligram, 10 milligram dosages. And another point was again, the efficacy was maintained till 52 weeks. So this is again a positive outcome. We are able to maintain, because what we have seen with biologics, especially these TNF alpha inhibitors, they start waning in their effects. So here, this is a good point here we can add on. So now when we talk about these adverse effects, they were really very few when we are talking about these 5 milligram BID dosages. The serious adverse effects were around 2.3%, and 3.4% of the people discontinued the treatment. So this has to be there in the back of the mind. With serious infections and opportunistic infections were there, malignancies were also there, and cardiac events were although zero, GI perforation showed were zero. So then let's jump to alopecia areata here. Here this alopecia areata, around 35 patients were taken, and the patients had a more than 50% loss of hair, scalp hair, and the disease was for more than 6 months. And this therapy was given for more than 4 months. And they measured the SALT score, all those people who had more than 50% response after around 7 months. So what did we find? Around 75% of the people experienced more than 5% change in the SALT score. And around 52% of the patients achieved more than 50% of hair regrowth after a period of 4 months to 24 months. So this is a big gap. And 8 patients, now this is worthy to see, 8 patients achieved 100% change in the SALT score after a period of around 10 months. So around a month, around a year, average therapy lasted for around a year. This is what I would say. Another case study was there. A 43-year-old woman had alopecia universalis, and she, after 6 months and after 12 months. These results are magical. But what I am yet to see these magical results in my practice. This another study was done in 66 patients, and here more than 50% scalp hair loss patients were seen. Were having alopecia totalis and universalis, and 5 milligram twice a day was given for 3 months. So what was the experience? Alopecia areata patients with Ophiasis, which are routinely very resistant to treatment, were more responsive, although patients with AT and AU subtypes were less responsive. So when we start off the therapy, these things are the prognostic markers. We need to be counseling our patient when we see and we talk about this drug to the patients. Don't promise a wonder drug. Don't ever promise it. Counseling is very important at every aspect whenever you need to start such drugs. So again, even after 3 months, the upper respiratory infection, which was a mild infection, was the main infection. There were reactivation of zoster in one patient, and very few of these other adverse effects. This is another case study, case report. Another a patient of alopecia universalis was prescribed 5 milligram twice a day dosage, and after 2 months, the dose was increased to 10 milligram in the morning and 5 milligram at night. So again, this shows very rewarding results. After 2 months, you can see the results. After 3 months and after the 6 months. So if after 6 months, if we are able to achieve such a results, then it is really promising. Same study with alopecia totalis, a patient shows very good results after around. Now when we talk about vitiligo, vitiligo again is a condition, a frustrating condition. A lot of hype was done with when we got this oral mini pulse, but gradually a lot of hype is always there in vitiligo whenever a new drug enters. But gradually we see we come back to square one. Let's hope we have something good in store for us with this molecule. So this was a retrospective study with 10 patients which was treated, and they underwent treatment with tofacitinib 5 to 10 milligram twice daily on an average for around 9 or 10 months. So what we found was a 5.4% BSA involvement with it. There is a decrease in around 5.5% area involvement in 5 of 10 patients. Here you can see in various studies around 4% area involvement, around 4% BSA area reduced. So although they are a bit convincing, these studies, but I think we have a long way to go still. Then this patient had a near complete repigmentation when he was given this 5 milligram twice a day dosage for around 5 months. So these are tidbit clinical case studies, but not much big, robust data is not there. Again, a patient was treated with 5 milligram twice a day for 3 months. The VASI score improved and gradually at the 5th follow-up. Again, there were around 20% had very few adverse effects, although of the mild nature, URTI, headache, nausea. Some of them had acne also. Now, another point was by using this tofacitinib along with the narrowband UVB. This I have started off in few of my patients, yet to see good results because it has not been much time that we have started off tofacitinib, and it is very difficult to conclusively say where I stand. But this result shows very good, although some of my patients have started showing results, some alopecia areata patients, some vitiligo patients, they have started pigmenting. So I hope for good. And again, this patient for the treatment, the dosage was increased to 5 milligram and they showed around for 20 weeks. And you can see the results. There is a very good result after around 5 months treatment. Again, a good result in the same patient around 5 months treatment. These are very difficult areas. If people can get treatment results here, then it is very convincing because these are certain areas where it's really resistant to treatment, especially these knuckle areas, especially these areas on the tip areas. When we talk about atopic dermatitis and moderate to severe atopic dermatitis was considered with more than 10% body surface area. Here the duration was around 29 weeks. Tofacitinib 5 milligram twice a day in 5 patients was given. And we could see in all the 6 patients, there was a very good decrease in scored rating. And the best part was, as I told you before, there was a very good decrease in the pruritus scores because these atopic patients are really worried about their pruritus. So here also, this drug could be of benefit. And here another patient with atopic dermatitis, 5 milligram twice a day for 6 months was given with good results. Another patient, 22-year-old man with atopic dermatitis, although what I could make in this picture, it is not very severe, but he improved. So to conclude, still, as I said, I think, I hope this molecule could be a game changer. Secondly, it is a good molecule. First and foremost, we should be well aware of the molecule, learn it, then use it. It can be of great help. It can be helpful as an add-on in our armamentariums, but with a caution. Although what I read, what I have learned, 5 milligram twice a day, people have been using for pretty long. And we were talking in the last seminar, people have been using 5 milligram twice a day for 1 to 2 years with very minimal side effects. So we can start off with a lower dosage. In case we don't get effects, we can increase the dose, we can learn the molecule and then start playing with it. So with these words, I stop sharing my slide. I thank you all for a patient hearing.
Thank you, Dr. Tarun Mittal. It was really excellent talk. In fact, I would like to say it was very comprehensive, covering almost each and every conditions and most of the thing which is needed in our day-to-day practice, in spite of your sore throat. So I'm thankful again. And now I'll request Dr. Rakesh Bharti to share his experience.
Sure, sir. Thank you so much. By listening to Dr. Tarun Mittal, I was just thinking, when will a day come when I can speak like him, like an academician in front of Dr. Devendra Prasad and Dr. Tarun Mittal? Hats off to you, sir. Dr. Saple very rightly said it was very comprehensive, very, very nice presentation. And while listening to your talk, despite my whatever experience, small little experience I have on the molecule, I have a few things were crossing my mind throughout. The one thing, when quinolones came on the scene as an antibiotic, there was a big headline in one of the newspapers that magic bullets have arrived. You also said that maybe it is a game changer which has come. And you said that there is a lot of hype about the adverse effects of tofacitinib. My mind says maybe there's a lot of hype even for its use. I really don't know that how good or bad the molecule actually is. The time will tell that where we stand as far as this is concerned. The other thing, other thought before I share my experience, Dr. Saple sir, am I allowed to do that 2-3 minutes talk?
Dr. Rakesh, everything is okay, no problem.
Okay. So the other thought was that he said use in vitiligo, use in atopic dermatitis and various CD8 cells and this cells. And when we talk of atopic dermatitis, he was talking about itching, right? So I was just thinking in vitiligo, there is a Cobner's phenomena. So if this molecule works for both ways, it stops the itch also and helps in treatment of the vitiligo also, what else? But as Dr. Tarun said rightly, the experience had not been that gratifying as far as vitiligo is concerned. But before that, I would like to show my some slides. Let me do a slideshow, and then I'll let you know. So this is how we go about. Just a minute, somebody is disturbing me. My experience. No, not when the Indian companies came with tofacitinib. I started using it way back when the 60 tablets will cost something like 25,000 bucks, which was a big deal. A young boy came to me, a young girl rather, I should say, from after knocking all the doors of all the pathies, of all the institutes, of various places, and she came all the way from around 250 kilometers to me. So how she came, I don't know. A young girl. I just explained everything. I was very, very cautious in using a costly medicine, number one. Number two, the side effects. But anyways, she and her parents, as they have by now tired. And, imagine a child of 16, 17 years of age going to school or the pre-college. Um, how much is the peer pressure? Forget about the disease, forget about the physical disfigurements. Think about the mental disfigurements this girl was going through. Besides the loss of total hair from the body and everywhere, on the scalp and the eyebrows and everywhere. So their parents were ready to do whatever investigations I ordered, and I definitely overstepped and did more than required, the investigations, and then was overcautious in starting the medicine. But the results were surprising for me as well as the parents. They were so happy, they were on cloud nine, and somehow this girl, and there was another boy who was going through all those rigmarole of going to various places, various institutes, various pathies, whatever. He was also about the same age as this girl was. So once the boy saw the girl's Facebook profile, he thought he should also come to me. So those were the days, when I started using, when it was available by a different name called Zalzians, right? And Indian companies were not that much there. And the results in these two patients were very, very gratifying. Now, seeing those results, I thought that not only the, people wearing wig and then, I mean, it is not easy to wear a wig. It is easier said than done. When a patient of alopecia comes to us, I always tell at least, that we have a cafeteria approach. We offer various types of coffees. Either you accept the reality, even for androgenic alopecia, or you do camouflage them by toupees, by patches, by wigs, or whatever, or you can try medicines, or as Dr. Vittal was saying to begin with, we started using pulse therapies. I am reminded of a teacher of my own medical college. She was a very senior teacher of anatomy department. She came to me with a small little patch of alopecia. I kept on reassuring her, ma'am, don't worry, you will be all right. You will be all right. You will be all right. She came to me after visiting everyone in the town. And unfortunately, I could do nothing. I could do nothing. This molecule was not available. She became bald. She started wearing a wig. And I cannot forgive myself for that failure. Because your failures make you feel that what is happening here? Why our science is not able to help these people? So the happiness on these two patients was beyond the words. And today also they are coming to me, they are off this drug now, because the biggest worry when we start this drug is that even if you get the result, the moment you stop, what will happen? On all academic fora, in WhatsApp group, we are listening to this, that once you stop tofacitinib, you are back to square one. I'm talking of alopecia. I'm not talking of psoriasis or vitiligo, anything right now. So this was a big thing, big challenge for me in these two patients. So what I did was, I started tapering tofacitinib, and I never exceeded 5 milligram BD. I gave only 5 milligram BD, not like Dr. Mittal, who says 10 milligram BD. I never. Not even psoriasis also. So then what I did was I added apremilast along with. And gradually, and I started with 10 milligram OD apremilast, and then increased apremilast, decreased tofacitinib, made it EOD, made it on a weekly basis, and gradually, both of these, my patients, over a span of maybe 3 years, or maybe even more, much more rather, they are off tofacitinib, they are off any drug. One of them developed a small little patch of alopecia areata later on, in which I asked, I should not have named anyway, a Capital's dermatologist to inject intralesional, and the hair growth came. So that was my experience with this. And these are the photographs, few of the photographs of some other patient, not that patient. And whatever I'm showing here in the center, I don't know how to use the cursor. If you can see in the central photograph out of the 5 in the second side, is 2 months later of 5 milligram OD only, not even BD, right? And then gradually things happen. This is the girl I'm talking about. Think about her. How was she going? And what is the result? Dr. Tarun Vittal showed one of the journals. I wish I could have published it. I didn't. I would rather perish with these photographs. I could not publish. Anyways, so but now my query is, my concern is, ever since these molecules of Indian companies have come, the results are slow, are not as effective. I'm not saying that use a brand of that company, but what I'm saying is, like biosimilars, there may be a difference in efficacy. There may be. I'm not, I have yet to give a proof to people that, look here, Xeljanz was better than compared to this, that of Indian brands. But definitely there is a difference, believe you me, guys. because now after these results, I have been using it very frequently. But that was a standard thing. Alopecia was written, psoriasis I never tried at that stage. And then next, what happened was a child came to me. You can see the photograph of the other side. I just thought that you cannot give oral medication to this. And we usually give, what we do is we either give tacrolimus or we ask for things like that. So I thought, let me do something different. So I got a tofacitinib made in 70% alcohol, 2%. In a month's time, I was surprised. I posted this patient's photographs in the WhatsApp academic group. And whereas everybody was saying, good, 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 Dr. V.K. Sharma said, who was professor and head, ex-professor and head now of AIMS, he said, maybe you have struck a gold mine in the treatment of LSA. So I thought, yes, maybe I was wrong in diagnosis vitiligo in that child, and it was basically a LSA and it worked, the JAK inhibitor, even locally. Or maybe I thought the time has treated her. Yeah, I cannot, or the medicine cannot take the credit. So next was I tried in an old lady, established case, who again came to me from 150 kilometers away, where the gynecologist said that it looks like it is malignancy. A biopsy was done. It was confirmed to be, and then, yes, the results are for everybody to see. The dyspareunia decreased, the pigmentation has decreased. Now, I don't know whether it works or not, but these are the two showcase cases I have where I thought that it is working. I'm still trying to use it in anatoderma and this condition, and partial results. Mind you, I'm using nothing else except this. Not that I'm combining it with a steroid topical or tacrolimus or something, nothing. So they're good results. Vitiligo, I burnt my fingers. No results were there. As a matter of fact, there is a hospital owner in my city who has some bad vitiligo. Doctors have showed some on the knuckles and this, and says it's very gratifying results here. Oh my God, he bought that old molecule, old preparation of 25,000 rupees. No results at all. In 6 months' time, we stopped the medicine. Now it has become cheaper. I have started again, but I have yet to see that is there any difference in that patient. But in this patient, as you can see, the dates are there. I made a 2% tofacitinib in 70% alcohol. Right now, I have stopped making in alcohol. I'm making it in Vaseline. And I have yet to record so many cases so that I can publish. But yes, there are few results. Others can try. And if they also find the results, then maybe we can do something different than others. Then the psoriasis. This patient had been coming to me since ages, was being given the gold standard poor man's biologic, that is methotrexate over the years. And then when things stopped working, he was ready to spend money because he was of a marriageable age. So Scafo was given, and then all biologics, and they used to work initially and then stopped. Doctors have said etanercept. Yes, etanercept, to my mind, is a very good molecule, especially if it is psoriatic arthritis. Not otherwise, to my mind. Anyways, everybody has his own experience. I feel that etanercept is good. In this patient, after everything failed and he was, a little in tears one day, I said, look here, guy, let me try a new medicine on you. And I started, he's happy. He's happy. Now he's on tofacitinib, 5 milligram BD. Same happy patient. You can see how nicely it has cleared, and it has not taken many months to clear like this. But I fear, as it happened with other biologics, this may happen in this patient with this biologic also. So I really don't know where are we going. Will it really be work? As I said in the beginning, if the hype of adverse effects is more, even the hype of use is more, to my mind. Hidradenitis suppurativa, nowhere I could not find some references except one or two. I have started in this girl a little bit of success, which may be, but in this case is not only tofacitinib. I have used along with the other conventional methods. I don't know what is working, but right now she's happy and I have not to give adalimumab to this patient. Well, these are only few slides I wanted to share, sir. Thank you very much, everyone, for listening to my all sorts of nonsense or sense, whatever you call it. Thank you.
Rakesh, it was really a wonderful experience you shared. And what we need is this information. Just clinical trials, clinicals are not done in our country. So what we need, I think already you have been expressed. I'm so much thankful.
We
I
have
thought what
sitting
you're going to show the
professors of
slide.
medical colleges, a PGI, so they can always do the trials and make me a partner and make me happy.
Yeah, no, it's absolutely right. No, this is a very good experience because this is going to give our colleagues confidence about this molecule. So now we'll open for the panel discussion. So I'll share my slides. Yeah. Okay. So I think we'll start with first question. I think I'll ask Dr. Professor Davinder Prasad. See, whatever the indications they have mentioned, Dr. Mittal, Dr. Rakesh, we would like to add more indications.
Okay. Thank you, sir. Thank you, sir. I have, listened to Dr. Tarun's very comprehensive talk, followed by Dr. Bharti's clinical pearls in his style, that Bharti style. So this is like, I'm always interested in mechanism of action. So Dr. Tarun nicely summarized that, but the crux of the matter is acting through the CD8 interferon gamma TNF alpha pathway. So any disease which has these cells a role to play, so can be tackled, like Dr. Bharti has mentioned about hidradenitis suppurativa. So where all these biologicals have been used, so one can always go for. So we have n number of indications wherever these immunosuppressive treatment works, like where we use methotrexate, where we use azathioprine. Even I have seen some of our colleagues trying in, as you are also listing here, in chronic actinic dermatitis, dermatomyositis, even airborne contact dermatitis, not responding to steroid or on heavy doses of steroid. So all such conditions characterized by increased level of interferon gamma TNF alpha pathways. So we can always think of this is smaller molecules and safer than the biologicals and cost effective. So these two probably we can play with this. Although there is a discussion about is in a magic bullet, definitely not a magic bullet, but it's going to stay for I think another 4 or 5 years. So we are newer analogs are coming, ritalcitinib or other newer analogs which are under phase 3 trials, so which are even more effective than tofacitinib and ruxolitinib. So probably the future is good, and we need to be watched closely.
Thank you, Dr. Davinder. What you said is absolutely right. There are many conditions, inflammatory conditions, we can use it, but still they are not approved, but we have to work on it. But as an off-label, when there are no other modalities available, as Bharti has a face, Rakesh has face, and he has used it because nothing was available. So always we can try, but as Dr. Davinder said, you have to be very careful while prescribing. We should know how to use it and when to use it. So we'll go for the next question.
The case report was, sir, they have used it in morphia along with methotrexate, and in LPP, morphia, methotrexate along with methotrexate, and in Lichen planus pilaris also they have used it. So these are two more entities where they have used this drug.
Yes, all inflammatory.
May I, sir, may I? I wanted to use it in a long-standing case of morphia in a small girl, not very small, almost reaching teenage. And but unfortunately, when I got her Montu and gold interferon, it turned out to be positive. Now I didn't know what to do. So the TB specialist in my town said, let's give her a course of rifampicin and Isonax for a month, and then you can start. I said, no, I am in no hurry. Let's wait for 6 months and then we can try. Now I really don't know once if I can get.
Yeah, I think that
the recommendation is, sir, you have to continue the treatment for at least 6 to 9 months. Then you can restart.
Yeah,
but there is no clinical evidence of tuberculosis, sir.
Yes, Rakesh will take up this question next. Okay. We'll go step by step. So these are the various indications, and there are many more indications. And as Tarun says, this is a game changer. So we'll go for the next patient. I'll ask Dr. Dimple. This is a patient of 45-year-old male with chronic plaque psoriasis for 5 years. Patient has comorbidity, that is diabetes, hypertension. He is on antihypertensive drugs and anti-diabetic drugs. Initially, this patient was started with the salicylic and topical steroid, but there was no improvement. Then patient was put on cyclosporine. There was very good improvement. But after some time, his blood pressure started rising and creatinine also started rising. So what we should do in this patient? Dr. Dimple.
Yes, good evening, everyone. So I think we are going on with a good discussion on a newer molecule. Sir, in this case of psoriasis, as we all know that cyclosporin has to be, just an emergency drug. We cannot use for longer times because of its ability to cause hypertension and raise the serum creatinine levels. So that cannot be continued for longer time. So we have to shift the patient again sequential therapies can be tried. I personally don't have any experience of using tofacitinib, but yes, it has given good results in chronic plaque psoriasis. And the studies have shown, the patient was started with methotrexate also. Sir, any more? Do we have any more information on this patient?
Yes, so we started on methotrexate, but he developed leukopenia, so we have to discontinue. So now what we should do?
So you can plan apremilast, sir.
Yeah, apremilast does work, but it takes a little longer. We have to be patient.
Plaque psoriasis, apremilast, I think there is a divided opinion. Many people say, initially it may not use with apremilast good as a maintenance. That's why.
Exactly, sir. But here we have very little options with us. Either we have retinoids to start with, or we have this thing, apremilast.
Apremilast will give results after a while. You have to be patient with that. Immediately, it cannot give effect.
Even
like cyclosporin can work in 2 weeks.
Stress buster thing. Even retinoids won't work like that.
Yes.
To my mind says, if you want, you can try etanercept and then switch to tofacitinib or apremilast.
Yeah, etanercept also can be given, acetretin also can be given. But we started this patient on tofacitinib 5 milligram BD, and see after 4 weeks, everything disappeared. This is I thought I'll just share my experience. This is about psoriasis. So next question is, I think I'm going to ask Tarun only. because they say that cyclosporine acts as a rescue therapy. So can we use tofacitinib as a rescue therapy?
These results which you showed after 4 weeks are amazing. But still, I am of the opinion to continue my confidence in cyclosporine as a rescue therapy, not tofacitinib. As of now, I don't have that confidence in the molecule.
Dr. Davinder?
Yes, I do agree. Like we do, I have seen also dramatic response in one of my case, but we need a larger study because in literature, I mean, as such, we don't have such kind of study to show that kind of efficacy for tofacitinib, but our experience are quite encouraging. So probably we need to have a good evidence-based study, so where we can be confident to say that this, yes, this drug can act as a rescue therapy.
Even I showed one similar patient, sir.
Yes. Rakesh?
Yes, sir.
Yeah, you would like to add about the rescue therapy?
No, I was just saying that even I showed a similar patient, but as Dr. Davinder is saying, and Dr. Tarun is saying, my faith still has to develop into this as a rescue therapy.
Well, it will sir, gradually. I think we need to know the drug gradually and have garner faith in it. And I think we will be able to.
I think after today's discussion, we should develop some faith in the drug.
Exactly. No, I tell you, sir, just for a moment, how I developed faith in this drug was I had a patient of alopecia, multiple alopecia areata with ophiasis, and I had done all things on earth with her. All and everything on earth, a PRP, a targeted narrowband, oral steroids, everything I had been through. Then I thought she was a dental surgeon. I talked to her, I counseled her, okay, let's start with tofacitinib. And the way it worked, it was really amazing.
Oh,
In
that's why
3
you're
months,
saying the game changer.
yes, sir. In 3 months, we and I and both of us were so happy. I can't tell you.
So, Tarun, this is one of my patient. This patient, we started tofacitinib 5 milligram BD after 2 weeks. This is the second, and this is the lesion. So he had an extensive. And the same patient, did we continue for 4 weeks? And you see, everything has disappeared. But as Dr. Davinder says, these are limited cases, what we are seeing. So we need a good study to support it. So I request your Hetero Healthcare, please arrange one study across the country. You can select the doctors and let's have a good study, because I was also under impression that cyclosporine is one of the very nice drugs and you get very fast result. But with the tofacitinib I'm using for last almost 10 months, almost 100 patients of mine are on tofacitinib, and in psoriasis, I got this result. So I feel it can be used as a rescue, but we need to study to support it. I entirely agree with Dr. Devinder.
Sir, one thing I would like to add here.
Yeah,
Sir, why do you want to say as a rescue drug? Sir, you can continue it. Cyclosporine, we have a problem to continue for long. But here we don't have a problem.
Yeah, but they say rescue drug means any drug which gives quicker response.
But we can maintain. It has an added advantage. We can maintain this drug also.
Yes, correct. Absolutely right. This is patient, another patient of mine. This is a patient with diabetes, hypertension, and pustular psoriasis. This patient was admitted in the hospital, started with the high doses of steroid because it's very difficult to treat this patient. But she was discharged with the 40 milligram of steroids. But then we reduced to 15 milligram along with tofacitinib. But she developed this. Can you see this shiny papule? So I was not knowing what is the shiny papule. So we did a 1 second. Biopsy turned out to be granulomatous rosacea. So, but we continue tofacitinib 5 milligram, and we reduce the doses of steroid. And now, if you see, after 4 weeks, everything is clear and only 5 milligram, and I'm maintaining her on tofacitinib. So even a pustular psoriasis also, because there was patient is hypertension, she is a diabetic, and the high doses of steroids, and I'm very happy with the maintaining this patient on tofacitinib. So we can use in a pustular psoriasis. That is how I use it. Tarun has shown these studies where psoriasis you can use 5 milligram or 10 milligram. With the 10 milligram, the results are better, and tofacitinib can be compared with the etanercept biologicals. But usually they said you can use topical, but topical ruxolitinib is used, but Bharti, you are used topical. Now you are using in not in ethanol, you are using in Vaseline, correct?
Yes, sir.
So how you make that paste or whatever the local application?
Sir, I have a pharmacy here, local. He's a very old chemist. He makes it for me. He has to use 40 tablets to make it 2% in Vaseline.
Okay, and these patients are happy with the application because I have not used any topical.
Yes, with alcohol it was difficult.
Okay, because you've shown that patient of vitiligo, Dr. Dimple, I think you also use it, no?
We've just used on a case where we didn't want to give oral, just a spot of vitiligo. I just mixed it in liquid paraffin to form a paste which was easy to apply. And a month's time, the patient showed some repigmentation, but we are still to validate the results.
But it was in paraffin,
liquid paraffin. Yeah.
The same 40
tablet was
tablets?
crushed. Yeah, tablet was crushed and mixed with the liquid paraffin.
Yeah, because I'm conducting this, many people are using either in a Vaseline. Most of them are using the Vaseline. Previously, they used to use in alcohol, but now they are using in the Vaseline and they are getting good results. I do not have experience about the topical, but I'll also start using it. So that was about the psoriasis. So we'll go for now the next case. This patient, I think I'll take with Dr. Davinder. That this is 35-year-old female patient. She had a dry, scaly, involving both palms and the soles with a lichen fied with scaly lesions in the scalp. She had a comorbidity of hypothyroidism. She was on Thyronorm 150 microgram, history of allergic rhinitis and asthma. So because she was suffering for 3 years, we did a biopsy, and biopsy confirmed or is supported our diagnosis of atopic dermatitis. When diagnosis of, so can you use immunosuppressant in this patient, Dr. Davinder?
Yeah, so but as you have shown the history, so just confined to the scalp and the palm and soles. So
yeah, but
rest
being
of the body,
female and 3 years, she was psychosocialized. Bharti has mentioned there are a lot of psychological problems.
Yeah, depending on that individual patient, if this patient is motivated enough, so we can go ahead with immunosuppressant, but in routine practice, so probably the severity is not that much to go for immunosuppressant. We will try for moisturizer, good moisturizer and topical agents for the localized area. But if the other body areas are involved and intractable pruritus with overt eczematizations, so then we straight away go for immunosuppressants. But these type of patient with a safer, tofacitinib compared to the other immunosuppressive agent has a better safety profile. So one can be just tempted to introduce tofacitinib a little early. So in such scenario, it can be one of the possibilities.
Yeah, thank you, and entirely agree. We should not go for immunosuppressant in the first line. Usually I use azithromycin. With azithromycin, we are getting, and with the local application, getting good result. But this patient, as we are preparing for immunosuppressant, her Montauk's test was 18 millimeter. So now, Dr. Davinder, what we will do?
Yeah, so as we have already touched upon this, Dr. Bharti mentioned about this, it's debatable. So one a group of dermatologists, they go for that preventive therapy, which is not recommended by the other group, because if it has to be tuberculosis, it has to be treated like a full treatment course rather than 2 drugs for 1 month as a preventive therapy. So we are not in favor of that kind of therapy. So we have to rule out clinical tuberculosis. So if we can rule out clinical tuberculosis, there is no need of anti-tubercular therapy. And if it's diagnosed as tuberculosis, then full course of treatment should be given.
I
Sir,
entirely agree
otherwise
with,
we can,
yeah, Dr. Dimple.
sir, otherwise we can land up with a drug-resistant tuberculosis also, which is very common here.
Exactly.
Yeah, Isonex, they said resistance is almost 80% in some of the places in our country,
Yes, sir.
but still it is used as a prophylaxis.
No, sir. Gold interferon should be done, number one. Number two, the TB specialist should be involved in between.
Exactly.
So if such patient, as Ravinder says, you have to find out whether there is an active tuberculosis or is a latent tuberculosis. For
X-ray has to
that
be
we
done.
need, yeah, we
X-ray
have
should be
to,
done, sir.
pardon?
X-ray, sir. X-ray should be done.
Yeah, X-ray, ESR, if the patient can afford.
We need to find out.
CTs can be done. Yeah.
Sir,
Yeah, the
instead it is
patient-
recommended, even for latent tuberculosis, if you want to plan, you need to go through the whole process of ATT treatment.
Sir, here I would like to give an opinion that we had a patient of pemphigus. So again, we needed to put that patient either on DCP or rituximab. The patient had MON2 positive, and I have a facility of taking opinion of TB specialist. My husband is one. We went in for HRCT, and then we did a bronchoscopy also, which yielded the result that patient was TB positive and he was started on complete treatment of TB, and with very low dose of steroid, his pemphigus is under control. So we are waiting that they have to complete the ATT, and then we will think of giving rituximab to that patient.
So the message is very clear. Whenever we are using any immunosuppressive drugs, country like India, whether we are dealing with the endemic tuberculosis, we have to keep it in mind about tuberculosis all the time. Whenever the patient comes to your clinic and the patient is on immunosuppressive drugs, especially steroids with a 40 milligram, 60 milligram, we have to think of TB, because we have seen many patients of pemphigus, they have developed reactivated tuberculosis. So only MON2 test is not enough. We have to go for a chest X-ray. We have to give ASR, and patient can afford HRCT chest or abdomen, and even the bronchoalveolar lavage in rare cases can be done. But now the question comes, if it is a latent tuberculosis, how you are going to treat this? Dr. Mittal.
Again, there are two schools of thoughts. Either you can go for a 1 to 2 month therapy, but being India an endemic state, they say you need to take the full 6 months course of therapy, even if it is a latent tuberculosis. So there are two schools of thought, sir.
Anybody else? Otherwise,
Sir, I will not treat. I will send it to the TB specialist. Simple as that.
Anyway,
I don't cross my boundaries.
Yeah, if it is you're sure it is a latent tuberculosis, the recommended internationally, because a lot of studies are there. These are the above studies are there. You have to give Isonex for 9 months to 1 year. And initially, even I never used to believe in HIV, but Dr. Bob Bollinger, who work in Africa, where the resistance to Isonex is almost 80%, by giving Isonex prophylaxis, he can prevent the reactivation even in HIV. So it can be given, but the problem is giving 9 months to 1 year. The problem is because there's only studies on Isonex, the compliance is only 47%. Many times we just prescribe for 6 to 9 months, but we do not know patients. So according to study, the compliance with the Isonex is only 47% to 53%. So just prescribe is not enough. So there are many other studies that are done. And according to the studies, you can combine daily for 4 months, or INH with reformation daily for 3 months. or you can combine with rifampicin. There are various, but rifampicin is not available in our country. So there are various regimens they have given, so we can follow any of them. But mostly we give Isonex for almost 6 to 9 months, but we have to be very careful about the compliance, because that is very important. So we'll go for the next case. On anybody has got any suggestion? I think I'll ask panelists, IGRA test and the MONTU test. We should do both the tests or one of the tests is enough? Because this question is asked very commonly.
Should I?
So these are just screening tests, and I think MONTU can give good result because it is quite inexpensive also for our patients.
Sir, after talking to some TV specialists, I have come to a conclusion that majority of the times MONTU test may turn out to be positive. So it is better to do at first go both the tests.
Anyway, so there are WHO
Rather than
studies.
doing MONTU first and then sending the patient to for the second test, you will say, why didn't you ask at one go?
Anyway,
The person who is ready to spend that much money, you know, even
Yes,
40
correct,
rupees
correct.
a tablet twice a day is not less. So if somebody is ready to spend that money, then he can spend tests, money on tests also, sir. This is my
Okay,
case.
so Dr. Rakesh says, I agree, patient is affording, get the both tests done, but according to WHO, MONTU test is enough, no need of getting IGRA test, because that is the recommendation of WHO, and I agree with them. In our country, MONTU test, I can tell you, if the MONTU test is strongly in HIV, I'm talking of the HIV because I got maximum experience, strongly positive. And if you get HRCT, chest abdomen, you'll find there is active tuberculosis. So MONTU test is very useful to find out the latent or active. Strongly positive, that is necrotic, more than 15 milligram, then you can think of active. Less than that, you can think of latent. So we'll go for the next case. This is a patient of 50 who complain of hyperpigmented scaly papule and excoriation all over the body for last 5 years.
Sir, Dr. Sable, sir, what does the law say? Because everywhere it is recommended for you need to go through a IGRA test before starting tofacitinib or JAK inhibitors. So if you don't get it done, are we liable
according
to
I'm reading WHO recommendation, there are 58 pages article on WHO and latent TB and how to find latent TB. According to them, MONTU test is enough, IGRA test is not necessary.
Sir,
it's a very clear.
Not liable.
Sir, with all regards to WHO, WHO has been telling that HCQS is working for COVID. Then it's retracted. Then so many things. Let us not talk about that. India is a different country. MONTU test will be positive in 85% of the population. Even you and me may test positive.
Yeah, that's correct. That's correct. It has to be positive. In fact, if it is negative, you should be surprised.
Yes.
See, in our country, it has to be positive.
Then how will we
but when it is positive, it's a mild, yeah, it's a mild, moderate, and severe. It is a moderate. Think of latent tuberculosis, no?
No, I agree, sir. My point is that if we ask for a MONTU test turns out to be positive, and then we ask now go for a IGRA test.
Yeah, if it is a MONTU test, but all can't afford. So the MONTU test is positive. Ask for clinical signs, symptom, chest X-ray, ESR. That will rule out or the contact that will rule out the active tuberculosis. If there is no active tuberculosis, treat as a latent tuberculosis. For that, you give Isonex, no, for 6 to 9 months, or you can give rifampicin, but with the tofacitinib, rifampicin cannot go because Dr. Mittal has said.
Somebody from PGI, Dr. Devinder is here.
Devinder, you go with your opinion. Yeah.
So this is good. Like WHO, for like from that point of view, looking at that infection is a different. While prescribing tofacitinib, it's a little different scenario. So I agree with Sir Dr. Saple, sir, for like the WHO guidelines are on MONTU test, which can correctly find out about latent tuberculosis when it's a moderately, and when it's severely positive, so it's very much correlated with the clinical tuberculosis. But often dilemma comes like when MON2 comes positive, then what to do? I mean, if it's still prescribed tofacitinib and patient develops tuberculosis, maybe a coincidence, then we will be in trouble. So we have to
Yeah,
go
that's
for
why,
IGRA test.
Dr. Davinder, we rule out active tuberculosis. There is no active tuberculosis. It as a latent tuberculosis. And we have to give Isonex at least 1 month before starting tofacitinib.
Yeah.
Yeah, that is the recommendation.
Thank you.
Continue. Yeah. Yeah, because this is a very good question, and everybody will have a problem, but it is made it very clear. If there is no active tuberculosis, treat as a latent tuberculosis. Start with the Isonex for 1 month, then start tofacitinib and continue for 6 to 9 months, but see that the compliance is proper. Yeah, so
I
can we
think
go for the next? Yeah.
RNTCP has made compliance also quite proper by giving, there are some incentives to the patients also who are put on ATTs. So that can ensure compliance for their good diet. So I think some 500
Madam, can you
rupees
say
or
loud?
something.
Madam, can you say loudly?
Some money is deposited in the accounts of persons who take ATT by the government of India. So that actually ensures compliance of treatment, which we are worried about in our patients.
Yeah, because short compliance for that, they come with the rifampicin or rifampicin, but rifampicin is not available in our country. But rifampicin is a problem with the tofacitinib because drug-drug interaction CYP3A4. That's why the rifampicin cannot be used with tofacitinib. We'll go for the next case. This is a patient of atopic dermatitis, patient of mine who was suffering for 5 years. He was given corticosteroid for a long period. He had a comorbidity, that is hypertension. He had undergone angioplasty, but there was no diabetes. Then this patient was given cyclosporine, but again he had developed hypertension. Then he was given biological. I gave him adalimumab. He was better, but after giving biologicals, when we discontinue, again there was a problem. Acitretin we could not give because of dyslipidemia. So because of all this, when the patient has started on tofacitinib 5 milligram BD, and after 15 days, these are the words of the patient, doctor, why are not given this medicine me before? Why have given so many other medicines? So he improved within 15 days, but after 1 month, he started complaining of body pain. He said, I'm getting pain all over the body. I'm not feeling well. So Dr. Davinder, what do you think of? Because he is on tofacitinib, clinically is very happy, but now he's complaining of body pain.
Yeah. So what other tests are available?
Yeah, so I did is this serum creatinine kinase, that was normal. LDH was normal because one of the side effects is rhabdomyolysis.
Yeah.
So I did that because we are still not much experience about this drug. So I did it, but both were normal.
So that is the only for the intractable pain, body ache. So if that is a normal, so probably in this case is rhabdomyolysis is not playing a role. Otherwise, we have to look for to rule out rhabdomyolysis.
Yeah, so I discussed with the many rheumatologists because they are more experienced. They are using tofacitinib for the last 3 to 4 years compared to us. So everybody answered me. I discussed with the 3 rheumatologists. They said this is a flu-like syndrome, like you give rifampicin with the tofacitinib, means also you get a flu-like syndrome and it will settle down. So I continue tofacitinib, everything settled down. So I thought I'll share my experience. So these are the atopic cases of mine. They responded very well within 2 to 4 weeks. They are doing very well. So I'm very happy using tofacitinib in psoriasis and atopic dermatitis. Of course, there's Tarun has mentioned about the trial about a 5 milligram and 10 milligram BD. With the 10 milligram results are almost 69%, 5 milligram 66%. Yeah, so already has mentioned about the vitiligo. I think this question I had to ask Dr. Davinder only. This is one of my patients with extensive vitiligo, and it's just, you mentioned the treatment, she has taken all treatment. Phototherapy, narrowband, methotrexate, steroid, azathioprine, cyclosporine, method, everything she has taken. But when she came to me, I said, why not to start tofacitinib? I was not knowing of the Rakesh is getting good result, but I also started. But after 2 months, Dr. Davinder, there was no change at all. There was no benefit. So what we should do?
Yes, sir. So I'll just take 1 minute. So for treating vitiligo, I always emphasize no drug can bring back melanocytes. So this is two entirely different things. The autoimmune damage leads to the loss of melanocytes. We need to act early when there are reservoirs there. So this tofacitinib falls in that group of drug, is quite effective. It can control the disease activity through this CD8, TNF alpha, interferon gamma pathways, acting through the CXCL9 and CXCL10 arm. Definitely, based on its mechanism of action, this is one of the ideal drug for the treatment. But in vitiligo, we have two aims. First is stopping the disease activity. Second is repigmentation, which depends on presence of reservoir of melanocyte. So if there are no reservoir, so no drug will going to bring back that melanocytes. So this is always a concern for vitiligo. We start trying newer drugs and look for repigmentation. So this is not the case. So first we have to look for whatever our objective for the treatment. So probably in this case, so there is a long-standing damage to the melanocytes. So as has not been responded to phototherapy.
Correct.
So we have to look for is very good drug. So what we need to know at which stage it acts. So if you identify those patients, so this will be going to be very effective. And with this cost effectiveness, we have started using it very extensively in vitiligo for controlling the disease activity, where we were using oral mini pulse, and we found it to be better than oral mini pulse in controlling the disease activity. And
we need
one
to
more
hit early.
Yeah, one more thing. So in vitiligo, we have an advantage. Like in psoriasis, we're using, like as Dr. Tarun mentioned, even 10 milligram VD, but here we can use even just 2.5 milligram. And this is advantage in vitiligo. We need a lower doses of immunosuppressant, but we prefer using like 2.5 twice a day. And moreover, the topical ritalcitinib, as has been shown in one of the pioneer study by Dr. Amit Pandya. So it's very effective, 1.5%. So topicals are very effective, but preparing ourselves in Vaseline or alcohol will probably not much of use. We need to identify good vehicles. So pharma industry take a lot of development work in developing these kind of vehicle for giving these type of drugs. So probably we need to wait for the market preparation, which are in phase 3 trials.
Thank you, Dr. Davinder, and you have made it very clear that the repigmentation depends upon the reservoir, how much the melanocytes are preserved, and that is a very good point. At least I was not aware of that. Sorry for that, but we have to learn from each other. So, Dr. Mittal, you want to add anything in this? Because
just I wanted to say that basically vitiligo we need to hit hard and early. Don't wait the disease to flourish. Hit it at the initial stage only. Then only you will be able to secure it.
so, according to literature, then I went to the literature, they say minimum you have to continue for 20 weeks to 5 months to get the repigmentation. That is a recommendation by the literature. So I continue this patient But then after 4 months, there was no result. So I'm discussing with you.
Sir, you increased the dose also, or did you not?
Yeah, 10 milligram. I made it instead of 5 milligram, 10 milligram. Yeah, but then consensus across the country, they said start tofacitinib with narrow band UV therapy. They do very well. That was the recommendation across the country. But I started this patient with narrow band, and now with tofacitinib, I'm waiting for the results. But other panelists, Dimple, you have this experience?
No, sir, we have not given
Yeah, but then
at right.
yeah, but this is the Dr. Anil Ganju from Delhi, Dr. Singh. They were saying they got good result of tofacitinib with narrow band therapy.
Sir, I am using with narrow band, and there are good results.
Okay,
I am using it with
good.
5 milligram BID dosage with narrow band.
Yeah, it makes sense. As I mentioned, so we need to make this melanocyte proliferate faster to give repigmentation, which is achieved by phototherapy. And tofacitinib take care of the immune attack, so no further damage will occur to melanocyte. So keeping these two in mind, so that is how repigmentation occurs and stopping of disease activity.
Yeah, so the consensus is tofacitinib with narrow band therapy is more useful compared to other. This is the patient of mine. We started on methotrexate. She was doing very well. In fact, she developed good hair growth. But when you stop methotrexate, everything disappeared. But when she came, she said, I don't want to start. So I started as tofacitinib, and you'll find out there was a regrowth. There was a regrowth, but the question comes, when you stop tofacitinib, the hair growth is going to disappear. So what we should do in this patient? Rakesh, I think you have got a good experience.
Sir, in one of my patients, I said I started along with the Premilast once I got the results, and then started tapering of tofacitinib.
I entirely agree. What
ultimately there was a patch left, which I asked local dermatologist wherever she was from to do an intralesional steroid, and things worked. And the patient is off tofacitinib, off Premilast, off everything.
Rakesh, I agree. In atopic dermatitis and psoriasis, eventually I put on apremilast, and that is another study I'm telling hetero. You see that because tofacitinib cannot be continued long time, and how long we can continue. So apremilast should be used as a maintenance therapy or the prevention of recurrence. So I'm suggesting healthcare. This is another study they should do across the country. Agree? All panelists will agree?
Yes, definitely.
Yeah.
Mittal, Tarun?
Yes, sir. Yes, sir.
So I suggested is up to them. This is another patient of mine.
And how many more?
Yeah, loss of eyebrows. You started tofacitinib and he developed eyebrows. But he said, doctor, I have developed eyebrows. What about my eyelashes? So who would like to take this question?
Give Lashishma
eyelashes.
Lashishma topical, sir.
Pardon?
I use Lashishma topically.
Yeah, that is okay. Yeah, along with that. But then I went to literature and they found eyelashes takes 5 to 6 months. Not like other alopecia areata, they grow far, but eyelashes take 5 to 6 months, and then it may require the higher doses. That is the literature says. So I'm waiting for this patient. He is on tofacitinib. As soon as I
topical,
get it,
sir, there is a study where topical tofacitinib has been doing good in liposomal preparations for these topical eyelashes and eyebrows.
Okay, then we'll try that. Huh? Thank you for the suggestion. So that is about alopecia areata. Now we'll go for, this is another patient of mine. He came, he said, sir, you started tofacitinib and I started losing hair. So is it because tofacitinib, Dr. Dimple?
So this can be because of some changes in the his bloodline. Like there can be some decrease in his erythropoietin works through this pathway also. So there can be some anemia or blood cells can decrease in that way. So this could be telogen effluvium also, rather
So,
than due to
yeah,
tofacitinib.
because this patient it looks like a male pattern hair loss, you know. Yeah, if you see the picture, it looks like I said this looks like a male pattern. History in the family, there is no history of family. But then patient asked, he showed me the bunch of hair. Like many ladies, they come, no? This man
So
came
that
with a
is
bunch of.
chronic telogen effluvium or acute telogen effluvium also, like we are seeing these days after COVID also.
Yes, okay. So I'm very happy, Dr. Dimple. Then we asked history. So we had a history of COVID about 2 months ago.
Yeah, so that is very common these days. People
Yeah,
who had
so
COVID in April, May are coming to us
yes,
with these
correct. So
problems.
any patient of COVID comes, invariably they come with the hair loss. So this is because tofacitinib plus COVID, both. Because usually the ladies, they come with a bunch of hair with this. But the male pattern, hardly I have seen they come like that. So from the history, the patient had COVID. Now this is another patient of mine. This patient had a hypertrophic lichen planus, 73 years old. She has got hypertension, no hypertension and no diabetes instead of 70. But she has taken all just immunosuppressive, just mentioned, systemic steroid, methotrexate, cyclosporine, azothar, everything was taken. So this patient came because she had a hypertrophic lichen planus. We did a biopsy. The biopsy shows hypertrophic lichen planus with pseudocarcinomatous hyperplasia. So how you're going to manage this patient? Dr. Mittal. Tarun is not around. Dr. Rakesh.
Sir, I think he
Hello.
was muted. Yeah.
Yeah. Anyway, so this patient, I started on tofacitinib 5 milligram BID. And you'll see, I was surprised, hypertrophic lesion disappear. Within 4 weeks, everything disappear. I did not expect that such a hypertrophic lesions will disappear, but it disappeared. But then we reduced the doses. But after 4 months, this patient came with the swelling of foot with tenderness and the redness. So Rakesh, what do you think? Dr. Bharti.
Sir, I have no idea. Sorry.
No,
It could be cellulitis to start with, sir.
Your
Could be
patient
cellulitis to start with.
A physician from a neighboring town just today showed me a similar patient, and I told him do a biopsy and rule out the vasculitis reasons.
No, but this patient is on tofacitinib of hypertrophic lichen planus. Everything disappear. We reduce the doses, but she came with the unilateral swelling of the foot, with the tenderness, erythema, and the redness. Dr. Davinder.
What is the lipid profile?
Cellulitis could be this possibility.
Yeah, yeah. So
Cellulitis.
this was cellulitis. Absolutely right. This was cellulitis. We treated this patient with linezolidine, and everything disappeared. So my question is to Dr. Mittal, can we restart tofacitinib or no?
Why not, sir? Why we can? We should.
Yeah, and what we should do during the infection?
We cannot start during the infection, but as soon as the infection settles down, we can restart the drug.
So we stop when the patient had infection, everything settled down. Now we are waiting for this patient. If we get recurrence, then we are going to start. But right now there are no lesions of lichen planus, so we are giving only moisturizer at present. But we will keep and watch. We do not know what is going to happen after 2 months. Yeah. So one of the reason they get infection. So usually, Dr. Davinder, who are the patients are likely to develop into infections, who are going to infection when they are on
Diabetics.
yeah, yes,
So
correct.
probably the comorbid condition like diabetes, obese patients, cellulitis of the, lower limbs could be the possibility.
Yeah, comorbidity, elderly patient, but patients who are immobile for a long time, they are likely to develop. Yeah. Anybody has seen herpes zoster after starting
Yes,
tofacitinib?
yes,
Yeah.
yes, I have seen.
So what you did,
Herpes.
Dr. Davinder, you just tell them. Yeah.
Yeah, a full course of acyclovir or valcyclovir and stopping this tofacitinib whenever reactivation or this present, when the patient present with the herpes zoster.
So there are two next questions about the malignancy and about the bone marrow suppression. So I think I'll ask Dr. Dimple, what do you think about, of course you have not used many, then I'll ask Dr. Mittal, what you about the bone marrow suppression and the malignancy?
We need to be monitoring it. Malignancy, more common with 10 milligram BID dosages or higher dosages, but non-melanoma skin cancers need to be monitored. And regarding the cytopenias, we need to continue monitoring our CBC counts.
So usually they said when they are using an organ transplant, higher doses, there are chances of malignancy, but with the lower doses, bone marrow suppression, malignancy chances are very rare. So I think I'll take one or two more questions. Local application we have discussed. In case of raised HGOT, HGPT, what we should do? This question is from Dr. Ashwini Gupta. Dr. Mittal.
Sir, I think it
HGOT,
settles down
HGPT
in a
is,
phase of 3 months.
pardon?
We need to monitor it, but it settles down.
Yeah, so you mean HGOT,
Moderate
HGPT
raise,
is raised, is a
moderate
mild, then you
raise.
can reduce the doses, and it is
Yes, yes.
severe, then it's better to stop it, correct?
Then we stop. Yes,
And you
yes.
can restart after some times. Question from Minaz Khoja. What is the monitoring required for the TOFA? I think I'll ask Dr. Davinder.
Yes, as Dr. Tarun has mentioned, like hemogram, lipid profile, and liver function test, and probably we don't need that frequently, like 3 monthly would be sufficient. And then as we have already discussed about Montu and IGRA test, so that can be done accordingly.
I think then I'll ask last two questions. I think first question I will ask to Tarun because he's contesting election as a vice president. So Tarun, tell me why dermatology should vote for you. Yeah, because why we should vote?
Very well said.
सर ये टॉफासिटिन से रिलेटेड तो नहीं है
ये
सर ने उनको प्लेटफॉर्म दे दिया.
This is very close to my heart, sir. Basically, what I feel, what sometimes I think in my heart is, I don't have those 100 papers in journals. I don't have that because we people in private practice, it is very difficult for us to document. Dr. Rakesh Bharti,
आपका
despite
दर्द मैं समझता हूँ सर
Sir, so we may see a lot of patients, but we don't have to any work to show to you people. But what I feel, what lacks in IDVL is there is a lack of connect in between the EC and the people. There is has always been a lack of connect. So I want there should be a connect in between an ordinary member and an EC. I need to be a friend in need. A friend indeed. That is what I just am there for. That is what I think. That is where an EC is required. I may not be an academician, but this is where I feel an IDVL is required by the ordinary member.
all the best
Thank you. And we'll go for the last question. I'll start with Dr. Davinder. What is your message about tofacitinib?
Yes, tofacitinib is a good molecule to be watched in a near future. So we have to be little careful about its indication. So it can be used in many diseases wherever there is inflammation induced by T cell, CD8 T cell, interferon gamma pathway, and it's definitely very, very effective. But we need to look the exact indication at which stage of disease we need to start. Like for every disease, we have a window where we can think of starting this tofacitinib. And if we found that correct window, so that would be a really good for patients. So this is definitely a very good molecule which has given us better, safer immunosuppressive agent.
Thank you, Dr. Davinder. Dimple?
Sir, I think with lots of newer molecules coming up, we should have better studies. The pharma companies can either sponsor them or kind of arrange them because their reach is for more people. And what is that they should not be introduced to every dermatologist should not be made aware of newer products. First we should have robust evidence to use these products. Only then we should start using them on a regular basis.
Thank you for a good suggestion. And I think we'll close after, as a Rakesh is one of the senior person. Rakesh, what is, now you tell why we should hold Dr. Tarun. Yeah. And
because
we'll hand over to
vote for him. I'm telling openly. But as Dr. Dimple said and Dr. Devinder said, I mean, I cannot add anything to what an academician of his caliber says. But what Dr. Dimple says, I slightly disagree, ma'am. You said do not introduce to all the
So
dermatologists.
No, not a dermatologist. The one, sir, I mean, like, I can tell you that, like, today I was introduced low bed GM, I got so wild at that person.
मेरे कमरे में आके दिखाए मेडिकल रैप में उठा के ना फेंक दूं तो.
So, sir, I mean, like, anyone who's an aesthetician also doing just laser therapies is also introduced isotretinoin and tofacitinib. So that was my, not dermatologist per se, but everyone who's practicing dermatology is not a dermatologist. I think you can understand that.
I agree.
Yeah. So that was my point.
Yeah, but for anything, if you have a study, nothing like that. Only just following the study in the other country is not enough. I entirely agree. I think I'll thank everybody and I'll hand over to Shweta. Yes, yes, yes.
Only he's ADVL friendly, he's friendly to all of us. That is why we should vote for Dr. Tarun Mittal.
Okay, thank you, Bharti. I agree with you.
Thank you, sir.
That we should vote for Tarun, and I'll hand over to Dr. Shweta for the thanks.
Thank you so much, sir. It's close to 10, and I'm really surprised with the enthusiasm of all the speakers, moderator, and panelists. I thank you, Dr. DG Sable sir, for showing such interest in the molecule and taking as the summary from ma'am to use the drug in the right way is in with the right people. I think is the key for this presentation today. Thank you, DG Sable sir, to moderate the session so well as always and guiding us throughout the use of tofacitinib in dermatology. I would like to also thank Dr. Tarun Mittal sir for showing such detailed mechanisms of each and every indication and exact use of drug, how it is going to work in all these indications. I would like to thank Dr. Rakesh Bharti sir. Your cases are really going to be a guide for so many other doctors for the right use of the drug. And I really thank you for that. Also, I would like to thank Dr. Davinder Prasad sir and Dr. Dimple Chopra ma'am for giving such insights about your experience of the molecule in your practice. So thank you everyone and the audience, of course, because of whom this session is going to be more and more, reaching to people. So thank you everyone, and I
So,
officially, yeah.
I would like to thank all. especially Dr. D.G. Sable sir, who has motivated us more for tofacitinib. We are better versed with the drug. And just want to say, learn the molecule. To all the newcomers, they should always learn the molecule, then go ahead. Don't jump to it. That's it. Then you will love the molecule.
Absolutely, sir. So thank you very much. I can
Thank you, everyone.
officially close the session.
Yeah, thank you
Thank
so much.
Thank you.
Thank you.
Stay safe. Yeah, okay, bye-bye.
Yes, sir. Good night, everyone.
Good night.
Thank you all.
Good night.